radiation exposure to diagnostic imaging and procedures and cancer treatment. What doctor and patient should know. Actually, medical imaging, of course, is not my expertise area, but I got some of the slides from the friends, so I try to explain some of the radiation exposure to them. So I have no conflict of interest. I think that what I'm going to cover is background radiation, effective radiation dose, radiation exposure limits, and shielding calculation, and radiation medical events, what it means medical events. And the final is my area, is radiation treatment, cancer treatment advances. So background radiation resources are coming from the cosmic, terrestrial, and the man-made. The cosmic radiation is basically some high-energy particles and the photons from the sun and other sources outside of Earth. So, but atmosphere of Earth provides a shielding of the radiation from outside. The altitude where we live is also have a different radiation exposure. If you look at the sea level, the radiation dose from cosmic radiation is lowest. But if you look in the Denver, is the highest, 50 mRAN per year, but 0.5 mRAN per hour at 39,000 feet. Why that means that most of the time international flight is that high. So it means that if you 10 hours, you basically multiply 0.5 multiply 10. It will be 5 mRAN for real international travel. Terrestrial radiation. Terrestrial radiation from radioactive materials occur largely in the Earth's crust. The lowest is again on the Atlantic coast, but the highest on the eastern slope of the Rockies Mountain, which is in Canada. About 30 milligram per year in U.S. population, remainder population. So regardless, you got radiation exposure every day. Then if you walk in the U.S. Capitol buildings, you get highest one per year, 85 milligram per year, because due to the uranium in the granite structure. So it looks a beautiful structure, but you got a more radiation, background radiation treatment. The main sources is medical use, consumer products, industrial uses, and the nuclear coal power. The medical sources, yes, majority is coming from diagnostic X-rays. This here is a 39 milligram per year in U.S. average. What that means is every year when you have total radiation exposure divided by U.S. population, that is the average radiation dose. But nuclear medicine is less, but radiation treatment is only 2.3 milligram per year. It's not because radiation dose is low. Radiation dose is very high. However, the cancer patient is, in general, is considered minority, right? So that's the average is still lower than the diagnostic X-rays for radiation protection standpoint. This slide is given by Dr. Lu. He just wanted education. He said X-ray CT procedures is X-ray passes through the body to form pictures. The MRI and ultrasound has no radiation. And the nuclear medicine, the small amount of radiation material is inhaled, injected, or swallowed by the patient. Then have special cameras outside to detect energy giving off by radiation material in the patient's body, and then form a picture. For example, the PET scan, the bone scans. This slide is showing that the amount of radiation dose received from the medical images. I want to highlight here. So most of the time, you guys like to order CT scan chest, abdomen, pelvis. Most of the time. Then it will be altogether close to 30 millicurie per year every time you order for the patients. Then we can talk about radiation limit later. This is the National Council of Radiation Protection. Most radiation exposure is regulated by this agency. So this slide is showing that the background radiation is number one. So the radon, and so on. Radon gas actually is more high in the background, in the basement. If you have a basement, you must, you know that what is the radiation radon level, because this is the background highest one you receive every day. Then this next one will be CT scan. It's 24%. But if you look at the actual background radiation versus medical use or industrial use radiation, it's probably 50-50. But in general, radon is considered the majority. So this slide is showing the detailed number of radiation dose. So before I give you an answer, can I ask you 4 questions so we can give a little bit more slides to explain to you. If the dose is man-made, is it more toxic than natural radiation? Can we show everybody show the hand? Yes or no? Say yes, raise hand. No to no. Okay. So very small percentage, less than 2%, more toxic than natural radiation. Man-made radiation is known to have resulted in new species of plants and animals. Yes or no? Yes means right. Yeah? Okay. Okay, that's good. That's probably 1%. The human body cannot repair damage from radiation, even if the dose is small. Yes means right. Low means not right. In the US, most cases of cancer are from man-made radiation. Yes or no? Well, let's see. What's the problem? So it means that we're all, majority of people are the physicians, right? You already know most of them. So 58% said answer is true. That's not correct. Man-made radiation is known to have resulted in new species. There's 43% answer is true. The human body cannot repair damage from radiation, even the dose is small. 50% answer is true. That's not correct. In the US, most cases of cancer coming from man-made radiation. The 38% answer is true. That is great. We are way above average. So what is the effective radiation dose? So the effect of radiation dose, there's 2 types. We always discuss that. One is called random, stochastic. As no threshold can occur at any dose, but have dose-dependent increase. The linear or linear quadratic model. The second one called deterministic, we have a threshold dose. Below that threshold dose, no effect. But above that, severity of radiation dose is going to be dependent. So this is the slides. I think that is showing that is what I just mentioned, that stochastic effect and the deterministic effect. So stochastic effect is basically the no threshold could be linear, it could be linear quadratic. But typically will be some mutations, cancer reduction. So that's what we estimate that. The cancer reduction and mutations has no threshold dose. Any dose can cause that. But for some of the late effects, radiation-related side effects, cataracts, mental retardation, probably has some of the threshold dose. Above that will be increasing. So this is the model we typically, for radiation protection specialists using, called a linear model, meaning that any radiation dose is detrimental. But this is just an estimation. No one has exactly right model. So the model could be, as we already said, could be deterministic. We have a threshold dose for radiation cancer reduction, which we do not know. So in that case, we overestimate low radiation dose causing the radiation treatment, because we receive the background radiation all the time. I'm just wondering if probably the incidence of radiation induced cancer is still may not be as we believe that high. The second model that some people say that, well, the low dose radiation can activate your immune system, activate your repairing system. So low dose radiation may be not a bad idea. So that's the typical E model. So in general, I just want to let you know that the current model we're using, the A model, linear model. So this linear model may be overestimated. Low dose radiation resulting in instance of cancer. This is the linear energy transfer called effective radiation dose. There's a formula. So when we talk about radiation, there is two types. One, radiation oncology and radiology, we're talking about radiation. We always talk about radiobiological effectiveness. So what that means is, radiation can have a variety of types of radiation. X-rays, we also talk about radiation like protons, neutrons, and carbon ions. So how do we know, how do we compare each other? So we're using radiobiological effectiveness called RBE. So those times RBE, those server, that's those equivalent dose when we discuss those patients. When patient receive radiation from these heavy ions, from protons, they come here, they want to know, we have to calculate how much radiation dose they receive, equivalent to the radiation in X-rays. This is the model they're using for the radiation protections. The radiation protection models is less accurate than radiation oncology. For example, typical example, protons, they're using 2. For us, we're using 1.1 RBE factor. And there is also the formula. Even the different organs in the body has different sensitivity of radiation. We all know that chronos in testes and ovaries as much more sensitive than other organs receive radiation treatments. And interestingly, most of the time we believe thyroid is very sensitive, but actually thyroid is not really sensitive to radiation treatments, to radiation exposure and stuff like that. Then we're talking about radiation exposure limits. There is a variety of agencies in the US and the international we have to follow. And number one will be FDA. And objective of radiation protection is 2 types. One is to prevent occurrence of clinically significant radiation-induced deterministic effects, means respiratory threshold. The second is limited stochastic effects to reasonable level in relation to the society needs, basically reduce the frequency of radiation-induced fatal events. There is another concept we call ALARA. Most of the time, radiation protection officer will tell you, means as long as is reasonably achieved. It means that making every reasonable effort to maintain exposure to ionized radiation as far below the dose limits as practical. So where that's coming from? That's coming from the safety industry. Look, this is not radiation. That's just a different job. When you work in the trading company, you have less chance to die or less chance to get fatal events, fatal accidents. But if you do the construction, in the mines, you're going to have a high incidence dying from this occupation job. So average, we think it is reasonable, acceptable in the population, will be 0.01 to 0.1%. So any radiation dose with cutting less than 0.1% is considered acceptable to the population. So this is the one for estimates, risk estimates for one server can producing 5.6% the cancer by radiation. So that's too high. So radiation protection called NPE, but maximum permissible dose is 50 milliserver. It's still too high. So a LARA dose is 5 milliserver per year. That is reasonable. That's where it's coming from. 0.028%. And besides the cancer inductions, you will see that the radiation, there's more reason that we also need and reduce the radiation dose as much as possible. For example, the radiation exposure to embryo or fetus is pretty high, causing severe mental retardation. The 1 minute for 40%, one server. This is just showing that the safety radiation, the summary recommended radiation dose limits by U.S. National Council. by international. But US is more restrictive than international. So, but in general, annual is 50 million surgery per year for us. But some of the numbers is different, but US is more restrictive. So for those like, what is the issue those for life-saving purpose? But if you are in a working job, you need to control the radiation for example, radiation exposure for emergency situations, and we also give radiation exposure limit. Typically, it's 0.5 gram, 50 rats. This is based on National Council radiation protection. Then we're talking about one more thing, is radiation sharing calculations. I don't think that, how many of you building its own practice using radiation, using X-rays? Thank you. Very small. I think I just want this one. I'm not expert on this one, but I'm just want to focus on the only things is 3 things you need to think about that. One is the workload, one is the use factor, one is occupancy factor. When you have time interval in a week of absorb the dose, 1 meter from source at depth of the maximum dose. The second one, use factor, means a fraction of the primary being's arm. Occupancy factor means a fraction of time that the maximum exposed individual is present while the beings are. So I want to skip this one, but if you need any help, I could introduce you one of our good physicists who can help you calculate what you need for the sharing factors. Another one I want to for medical events. What means medical event for radiation oncology and radiology and any industry related to radiation? So the different from, so I would say this is too much here for your understanding. For radiation oncology, we are using this. Total dose delivered differs by 20% for prescription, or 50% for more than 50% of each fraction. If that is dose is more than that, it's considered a medical event. Then administrative activity differs, typically by nuclear medicine, different from prescription by more than 20%, with outside the radiation dose range. Besides that, the second one will be covered. Anything is wrong patient, wrong route, wrong pharmaceuticals. If you really dose more than 5 grams or 50 grams per organ. And finally, there is another definition for medical event. Any event resulting from the radiation exposure procedure, and that causes unintended permanent functional damage to the organ or physiological symptoms. That's also considered a medical event. So once the medical event happens, what do we should do, right? The number one, reporting requirements. We have to report, sometimes we do. We give the patient a treatment with wrong radiation dose. We have to report analysis in 24 hours by telephone. 15 days written report. And then we have discussion instance and the cause, the effect on the individual involved, and propose the corrective actions. We have to, how we can prevent in the future. It's a big event. Referring entity must be informed. So that means that if we give radiation, radiology, radiation oncology, give one of those radiation medical events, we have to call primary physician right away, 24 hours. The patient, this is another interesting point. The patient has to be known. There's a loose criteria. You do not need to tell the patient if you're judging. If you feel that the patient is not mentally stable, you don't have to tell. So the patient is to be notified by referring MD, not by us, if necessary. But most of the time we do tell the patient right away. Or at least get the patient and family involved in discussion. Then release of the patient. If this happen medical event, if the total dose is equivalent to anyone less than 0.5, that's okay, then release them. Typically, radiology. And provide region instruction if more than 0.1, then likely give ALARA guidance, breastfeeding instruction if the woman, and potential consequences, and the records for authorization release and the breastfeeding instructions. I think most of you are interested about what is the declared pregnancy. The pregnancy is the issue. issue is that woman who has voluntarily informed the we call IS, radiation safety officer, in writing of her pregnancy, estimated date of conception, then declaration remains in effect until the woman withdraws the declaration in writing or is no longer pregnant. So if you declare pregnancy, the woman must wear 2 badges. One badge is commonly we wear, called on the collar, another badge on the fetal monitor, one at the waist area. And then we also have, if the job has changed, make sure the lower occupational radiation dose limit as possible. So this is this general, I think it will be easy to remember. Is the member of the public is 100 milligram. It's pretty, any dose limit. And basically, if any PET scan you have, more than that. But if it means that if you don't need a PET scan, don't need images, don't do it. The radiation worker the radiation dose limit is higher. But for fetus, is 500 milligram. Again, if you need any images, CT scan stuff, well, more than the limit. And also further requirements is less than 50 milligram per any 1 month during the pregnancy time. This is provided by Dr. Liu. He just mentioned that. I think most of you already know. Most sensitive risk type is first trimester, 3 months. And less than 6 months, after 9 months, it's pretty close to normal. And he also provided a slide saying that sometimes you have to. For example, in this case, MVA, motor vehicle accident, the patient has bleeding, and this is the diagnostic CT scan. It's only give you 20 minutes a grade, but it's still more than the limit. But then this patient have blood, outside need surgery, and same thing like this too, and the need CT scan to help for treatment. Finally, I'd like to talk about cancer radiation treatments. The cancer radiation treatments is something that it's very in many public mind that radiation is kind of like a cobalt-60 type of radiation. But now it's different based on technology. And it is indeed back to from 1896 up to, I would say, close to 2000. At this time period in time, is radiation job almost no job. Radiation oncologist is almost no job at the time. Back in 2000, there's a revolution we call ANACP, intensity monitoring radiation treatment, based on CT plan. Then we have 4D CT. Then we have imaging guided radiation treatment. Means that every day we do radiation. Before that, I have imaging guidance, accuracy. So that is the starting point. Minimum is 2006. That's bring the revolutionary change for radiation oncology. So now it's adaptive radiation and mRNA accelerator. Now these days, if you visit any radiation oncology department, you will notice that this is the monster machines is in the radiation oncology department. And this is just give you accuracy for radiation treatments. So now these days, for almost all the body, any portion of the cancer treatments, we can have focused radiation to where we want to treat. We also understand that during the course of radiation treatment, radiation everyday treatment, we know that interfraction change means each day the cancer is moving, organ is moving. And also have intrafractional, which means that during course treatments, another 5-10 minutes time is also moving. We understand that too. And also we understand that change, anatomy, size, shape during the course of radiation because of imaging, and also biological based on oxidation, metabolic level, and proliferation level. So what we can do dealing with the motion, for example, for prostate cancer, before radiation treatment, we place 3 fiducial markers there, the inside prostate glands. So we do X-rays every day, we do the CT scan every day. We also can do ultrasound. During the course of radiation treatment, we monitor the process moving. And also for the chest, for lung cancer, breast cancer treatment, we also can do motion. The optical imaging, you can see the changes. Based on the changes, we monitor. So, this one is not, I'm sorry, the video is not working. So basically, we know that the video, we can see the lung cancer, you can move up and down, up and down. This is the tumor is here, and we can go from here to here. That can every day. Right? Video is not on. We can see that. So how accuracy we can give radiation. And radiation dose we're giving is common radiation treatment, 25, 40, 45 treatments. It's acute every day from 25 to 45. And then we also do a hyperfractionation radiation treatment, try to reduce the time for radiation treatments. And we're also talking about surgery. We're talking about radio surgery. It's not really surgery. It's kind of a marketing. The stereotactic radio surgery or stereotactic body radiation treatments. And typically with one fraction, less than 5 fractions. And typically the radiation dose are less higher per day than the radiation efficacy is increasing dramatically. However, the side effects is higher. And for example, for prostate cancer treatments, this is how prostate treating prostate and seminal vesicle. And here we can treat the prostate and also lymph nodes. The radiation dose will accurately deposit to the area we want to treat it. And besides XOV radiation treatment, we also can do the brachytherapy, which means in OR, working with the surgeon together. And we can do electron beam radiation, we also electronic brachytherapy, we have seed implants, we can high dose with brachytherapy. And for example, this is the seed implants. During the OR, we can, using ultrasound guidance, place the seeds inside the prostate glands. And obviously, some technical error could happen because in the OR, bone marker, we cannot predict. Sometimes seeds is not what I want to go, but most of the time it's accurate. I would say 80%. 10-20% is not accurate what I want to go. And then we also can do what we call high dose brachytherapy, temporary implants. Once we place the plastic needles inside the prostate gland, then we give a high dose radiation. We know what we're giving. Then afterwards, we remove this implant. This patient has no radiation in the body. And for example, like a penis cancer, and this is stage 1 cancer is here, penis cancer. If you have a surgery that will partial colectomy, for me, we give radiation. We just implant this 8 needles. The patient no need for surgery. Then we give radiation, and we can get CAT scan, radiation planning, then we can see the cancer is gone. Then also we can, for GYN cases, we can do XOV radiation combined with the implants to the cervical cancer to get rid of that. So no need of surgery in these days. And for example, like this patient with oral tongue cancer is a lawyer. He doesn't want a surgery. And half tongue removed, this is my job. If you remove my tongue, I cannot talk, I cannot function in my job, do my job anymore. So we put implants here, partial implants treating this area. The patient is still able to talk. It sounds like crazy, look at the images. But after radiation, 12 days, patient go home. 1 month later, he can talk. And for example, like the sarcoma patients, once the patient has radiation before, what we can do, we have surgery, remove them, and put implants here. To give more high dose radiation. This afterwards, after CT scan, then after implants, we do CT scan, then we contour where we want to treat, and give accurate radiation dose to these places. And there's another one, sarcoma, one chest wall sarcoma. We can have surgery, then put implants, radiation, then do plastic surgeries. And now with the new technology coming, then we have seeds, and one side of radiation seeds, another side is a gold, and melted together. So that this is how flexible it is during the surgery. You can place the tumor, surgical bag, and look at the radiation dose. Radiation dose only one side. On back side, almost no radiation treatments. So it's radiation protection in the normal tissue organs. For example, this is the case we did, and it's big sarcoma, and the surgical resection is done, then surgeon and I placed the silver sheet and the mobile this ureter out, and just put this radiation dose here. Then on the back, we put an elegant graft so that organ can, after surgery, doesn't long organ like bowels and the kidney will not receive radiation treatments. Only in the tumor bed will receive high dose radiation treatments. And this is, can image that afterwards, 1 week, 2 weeks, 3 months, and we can image that what is where exactly when is any moving during the time. So I thank you very much, and currently I want to give the credits for Dr. James Xu, who is retired the chief physicist at Rush, and Dr. Yang Lu. He sent me some of the slides, and also he showed his picture here. So remember him, he's now moving to MD Anderson. I want to show you one thing. Dr. Joe, can you help me? Yeah, I want to show you one thing. Since you're all your physician here, I want to advertise, give 1 minute. I'm the editor-chief in the Real Tumor Journal. So if anyone has interest in, has become a real tumor, want to, I think it's a lady. I think at any time has interest in to submit your manuscript to Real Tumor, let me know. Thank you very much. Thank you.
Questions? Okay.
Thanks for bringing this topic here, and that's so interesting. And my background before is a paleontologist, and right now I'm training the physician in China. A lot of questions, and the community physician and ask for about the radiation and the fetal toxicity. And you already talked about the sensitive period is during the earlier first trimester. So then the second one is the how much, like X-ray, pelvic, abdominal X-ray, and the CT and the MRI. How based on this, how much to make a decision? And the keep pregnancy and another keep pregnancy, I usually like them to go to the paleontologist to make a decision.
As I mentioned that, if you look at the radiation dose limit, any CT scan is over the limit during the entire pregnancy period of time. So awarding that, that's no question. And 100% awarding that during the first trimester, first 3 months. After that, there's no bigger data there. And I always say it's low. You said 97, less than 97% is acceptable to you. If less than 1 to 3% acceptable to you, I don't think it's acceptable. The lots of babies, right? If you have 1 to 3% of lifetime, it's seriously significant things. But only just if needed. If you really need a surgery, or need a radiation, or need something. Otherwise, don't do it. Nobody knows the limit.
In other words, from this point, if they got the first trimester, if the mom get the CT, and that have a risk, so then the next decision and is do you keep the baby or not keep the baby?
That is a good question for you, not for me now. we only tell you the exposure, what is the risk. But in general, you should tell the patient that you have the risk, baby has a risk for mental retardation.
What is the percentage? What is the percentage? 1%?
1%, yes. That's a percentage-wise, it could be depending on region dose. And if you're using one silver, it's 40% for severe mental retardation. If you're less than the dose, you divide it by 10%, it will be still 4%. So it's hard.
Again, medical oncology from New York. We use ton of CAT scan, of course, our profession. We know radiation can cause cancer. The most data is come from the Hodgkin lymphoma, early stage, 20 years ago, we treated with the MENT, I believe it's mental, whatever field, extensive radiation. After 15, 20 years, a lot of people start to increase breast cancer, sarcoma, blah, 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 now we know. The problem is that I think the CAT scan, although media know, they're sort of overrated. I really want to know, is there real data show how much percentage the CAT scan could cause cancer, and the duration most important. Because usually I tell my patient, you're 70, I give you a CAT scan, I don't care, 20 years later you're not alive, because we think the risk is 20 years later. But when I give the recommendation, for example, I made my husband do a CAT scan not long ago, after your talk, you will blame me. But the question is really, how long the duration? Do we really care when you are 70s or 80s? I mean, stage 4 lung cancer patients, stage 4 cancer, I don't care. I tell them, you survive first, right? I have to know whether my treatment is working or not. But if see people healthy, you're debating whether CAT scan is necessary or not. So I usually tell them 15 years, 20 years, you're 90, you care. I wonder if my statement is right or not.
Well, number one, and radiation induced for radiation treatment induced the cancer, yes. And we all have data on that. You know, for the young kids, Huntington's disease, receive a mental radiation treatment at that time, more than 36th grade. It's pretty high, very high. But 40% chance in lifetime developing breast cancer. There's no argument for that. In terms of CT scans, images, and I do not know if we need any CT scan after 5 years. There's no data. But I know that we sometimes still order that. But we like to order first 5 years. And but the question is later, what is the data to? Number one question is, what is the benefits of that? If a patient is doing well, and come back once a year for follow-up, blood work is fine. I don't know if we really need it 10 years later, still need a CT scan. That's my question. I don't know. I think the CT scan gives us some low dose exposure. Does it matter? When you look at the general population, the limit, yes. But if you once a year to give that as 10 minutes a week, maybe it still is okay. But my question is, what is the benefits? I don't know if I have the answer for you. Thank you.
我有一个问题，我不知道你能不能回答下来。就是这实际上是一个 legal issue和这个 ethical issue。就是我觉得就是好像我看过一个文章，就是说如果病人去做 CT scan，right， you should cover other part which is you don't do. For example, you do the chest X-ray, chest CT. You should cover ovary and cover the thyroid. But if patient ask, some people will do. If patient didn't ask, like I forgot to ask, so they will do the CT scan without cover your thyroid, without cover your productive organ, for the young people. I think this is is there any real guideline to ask radiology? You should protect. Although you say the dose is very small, might not be effective, but even the X-ray, right? You do the chest, and then you should cover other part, right? This is like an ethical issue, or should have guideline on that. And for the long run, I think if any lawyer wants to make trouble and to sue you, like a big radiology practice, and then you can get a classic lawsuit about that because you do have risk. And I don't know if you can answer that question. Is that every procedure you should cover the part which you don't do the test.
Thank you. I think there's any radiology in the room. Okay, let me answer your radiology. Okay, can you answer the first portion?
Mostly depends. I think for the young people that we cover most of the thyroid stuff that we cover them all the time. So for the young people we cover and also for patients with breast cancer. But sometimes if you cover the part, they can affect. And not hear you. Test.
I'm going Yang from here, Chicago. Yeah, and it's kind of still a gray area, so it's difficult to say which is right, which is wrong, and we try to cover as many arteries as we can, especially for the young people, pregnant people or kids. Thyroid is not like a main concern for the technologists. Sometimes they are more aware about this, but if you cover some of the part, it can affect your skin. And then most of the doctors don't like it, so we just don't cover it. But for the young people, we try to cover as many places as we can. But I don't think there's a guideline or anything like that, but there's a guideline probably for the pregnant ladies and the younger kids.
Thank you. A dumb question to you. But my first radiation oncology point of view. we have not protected any other area during the course of the except some of the places, like we want to prevent the cataract, to decrease those to the threshold. As long as we calculate, decrease the threshold, we're not worried. Because there is a really good CT industry showing that between 0.01 to 0.1%, less is considered safe for the patient. So I don't think there is a guideline. I agree with you. I did a CT scan myself. I don't think anybody has the guidelines to do that, and I don't think a lawyer can sue that.
Sorry, I have a question. Regarding the sensitivity for tumors, what kind of tumor you think is more sensitive to radiation therapy? And particularly the sarcomas, it's growing kind of slow. Is it still going to be sensitive for radiation therapy? Because we sometimes we talk with patients, I got some kind of slow-growing tumor like sarcoma. Are they? I mean, according to my knowledge, it's not really benefit in 5-year survival for radiation therapy for some kind of tumors. Can you give some kind of suggestion? What kind of tumor you really going to suggest? What kind of tumor you don't suggest because it's because damage, not much benefit.
I'm sorry, you said radiation treatment to point of view.
Right.
Well, since you asked the sarcoma, I'm the chair of the sarcoma working group.
Right.
Nationwide.
That's one.
But in general, sarcoma is not, in general, considered radiation-resistant disease compared with like breast cancer or other type of cancers, like lymphoma. But still, it's very sensitive to radiation. We all recommend the pre-op radiation treatment followed by surgical resection in majority of soft tissue sarcoma. There is almost no cancer these days, say 100% resistant to radiation treatment. I think the bigger ones, or the very difficult ones, actually the GBM. Perhaps the speaker talk about that too. But GBM actually is a really, really bad tumor for radiation treatments. Not very sensitive, but we're still giving. It's always have high local recurrence. I don't see, but anyway, answer your question. I do not think any tumor, say, do not need radiation if it's a malignant. Only say the benign tumor may not need radiation.
Yeah, I have a question. So first question is about fetal protection for the images. I think you addressed a lot about the CT scan. My question is, how about if the pregnant woman, if they have some need for image study, can you use the MRI? Is MRI considered as a radiation or not? In my understanding, MRI have no radiation. If please address the MRI issue. And then the second question is this: I'm doing pain management, use radiation a lot. So for the physician protection, let's say we wear those fine protection, everything. Let's say per day, how many procedures we do consider is safe for the physician? Or if you say we should limit our patient use fluoroscopy 2 a day, or 5 days a week, will be safe for us? I know those numbers too big for us to understand. Just say, okay, you cannot do more than this, otherwise you have a chance to get cancer. So I'd like you address that for our physician's protection. And number 3 question I have is about PET scan. A PET scan is a kind of CT. I don't know the radiation exposure is a higher dose and then also lower dose than the traditional CT scan. Number 4 question is, let's say, when your penetration distance, too much?
All right, I think
You want to stand in here too? I think the MRI is not radiation, no radiation here.
last one. Lucky one.
Yes.
But in other ones, status or some of the stones, the US stones, and will still have to see or some. Well, they are alternatives, like quick shot or something like that. But for the yes.
Thank you for your confirmation. MRI has no iodine radiation, so it's okay, it should be safe. On the second question, I think you can answer that question too.
Contrast.
Oh, yeah. the contract is different. It will be caused part of other issues. Besides that, it's also called renal failure issues. On the second question regarding your X-ray exposure, I think my wife is also concerned about that too because he's doing the procedure all the time. I think the fluoroscopy in general is one CT scan equivalent to 150 to 250. It's fluoroscopy. Is that right? So apart by that, so it's pretty safe actually. Yeah, but as long as your body is not in the radiation field. Just make sure, because when you have to do procedure, it's a lot of times I'm forgotten. Your hands are still there. You get X-rays directly. There's no need exposure for that. Number 3, what is number 3? Anybody help?
I'm an obstetrician gynecologist from New York. I want to make comments regarding here. I want to make comments regarding the safety of radiation during the pregnancy. And we talk a lot, and I think that we OB/GYN share a different opinion with your radiologist or radiologist. And generally speaking, we think that CT is pretty safe during pregnancy. At least have one exposure. Especially for one abdominal CT, there's no problem. And we know that as long as the radiation is less than 5 reps in one exposure, that should be safe. And then we know from the radiation dose, and if patient has one ERCP, the dose will be close to 5 reps. The one abdominal CAT scan, for sure, is lower than that. However, we are very safe to order the CT, but the patient and also radiologist always give us some concern. And the patient concern is really understandable, but we also have always a lot of radiologists give us a very high resistance regarding to perform this procedure. That's why, from obstetrician point of view, we seldom order abdominal CAT scan only if it has a strong indication we don't have any other way to avoid this procedure. And also in the early pregnancy, and we don't care too much about the radiation because we know the effect is on and off. And if the radiation has the effect, even the examination, if less than 5 reps, there should be no problem. But 5 reps, I mentioned, there's a very strong rep. That's very strong radiation. And if the radiation has an effect on the early stage of the embryo either cause loss of function and the pregnancy will end in miscarriage, or there's no implantation, and there's no effect at all. So that's one kind of
Thank you very much. I think for your clinician point of view, but I think from radiology, I'm not a radiologist, but I know the radiology point of view, you're over the limit because you're 10 minutes away from the each radiation abdominal CT. In entire pregnancy is only allowed 500 milligrams. So that is the radiation to the safety protection, the limits on that. But if you have absolutely indicated, like Dr. Lu showed me the slides, you have to do it. But probably still safe. The safe means that probably 10 years, 20 years, 99% of the time still is okay. Life, no issues. But do you accept that 1%? This is the question. Some 2% accepting. Well, I remember your last question, PET scan. Don't forget. PET scan, the radiation dose because the radioactive isotope is much higher than CT scan.